All right, here we are, Kinesiology 230. This is chapter 19. We're still talking about clients with metabolic or nutritional or metabolic concerns. We're into presentation number 6. This is about metabolic syndrome and diabetes mellitus. And for some of this, it's highly specialized stuff. And when a client comes to you and they have diabetes, they'll know already. But with metabolic syndrome, they talk about metabolic syndrome being a progressive pathophysiological state that puts a person at increased risk for developing metabolic disease such as type 2 diabetes, atherosclerotic cardiovascular disease. If you want to just go ahead and win at Scrabble, use that. And the components of this include obesity, atherogenic dyslipidemia, meaning hyperlipidemia or low HDL cholesterol, or both, elevated blood pressure, and insulin resistance with or without glucose. Now, I would tell you, these are very interrelated and are very much tied to fitness and being in shape, and having exercise as part of a routine helps abate these. Now, they talk about abdominal obesity, Android, meaning Apple. They also talk about hyperlipidemia, meaning increased lipid profiles and or having low HDL. You have an elevated blood pressure, the insulin resistance we'll get into, and they refer to this here on out as MET-S. So don't get confused when they say MET-S, it means metabolic syndrome. And these are the bullet points they give to you. And we use these in another class, and we start coming up with contraindications to exercise for a person in this American College of Sports Medicine algorithm that we use to help categorize people and exercise readiness. Abdominal obesity, their waist circumference greater than 40 for men, greater than 35 inches for women. Hypertriglyceridemia, meaning above 150 milligrams per deciliter. And then reduced HDL cholesterol below 40 below 40 in men and below 50 in women. Elevated blood pressure, and it's an either or. There's also another subcategorization for both, but just in general, think of it in terms of greater than 130 over 85, and a blood glucose higher than 100 milligrams per deciliter. And the passage to the right does a pretty good job of kind of providing an overview here, and I'll let you pause and read it. I'm not going to bury you guys by this, but they talk about how very low density lipoprotein molecules transport triglycerides, and VLDLs convert into LDLs, etc., and the LDLs, cholesterol molecules. It actually does a really good job of kind of wrapping this up. But I will say this, both exercise and good nutrition are appropriate strategies for metabolic syndrome. We talk about all the time. If you want to abate many of the hypokinetic injury or illnesses, start moving. That's all you got to do. So it's diabetes mellitus itself. It's a group of metabolic diseases characterized by high or uncontrolled blood glucose levels. And you have two separate fasting glucose measures that are done. And if these measures are over 126, then they would be classified as diabetic. It can also use a two-hour post-meal measurement as well, but the more accurate is the 126 with fasting. And the book notes 3 different types of diabetes mellitus: type 1, type 2, and gestational, which we talked a little bit about already in specialty populations with pregnancy. So with the 3 types, type 1, it was known as insulin dependent. It's long story short, the thing they want you to take away from this is exogenous insulin needs to be injected, meaning exogenous means from the outside, the body. Needs to be injected or introduced into the body via pump, and this is required for survival. If they have undiagnosed type 1 diabetes, they'll end up with diabetic ketoacidosis, and it's the accumulation of ketones. And what ends up happening is the person will end up having frequent urination, nausea, vomiting, abdominal pain, and lethargy, and eventually they may progress to a coma. Type 2 diabetes, on the other hand, non-insulin dependent diabetes mellitus, as it was once referred, is 90% of the cases of people with diabetes. And it's usually associated with some family history of diabetes. It's older in age. People who suffer from obesity maybe make poor dietary choices, and they lack exercise. The treatment for type 2 diabetes is different than type 1. It includes diet modification, weight control, regular exercise, and oral hypoglycemic agents. So to a certain degree, this is the population we can work with the most. And many times people will come in and say, I'm borderline type 2 diabetic. And it's probably because they're obese and they have poor diet. And you just have to work with them to kind of pull them back from that ledge. But I will say this, the people that come in who are type 1 diabetic know they're type 1. They've treated it their entire lives. They know the warning signs. They know the symptoms. They know what happens if they start to get a little bit too tired or too fatigued. And they know, as a result, how to manage their condition. Type 2 people, many times they'll come in scared because they just found out from their doctor they're type 2 diabetic, or they're riding along a threshold where they're almost type 2 diabetic. And you have to kind of guide them down a path to explain diet modification, weight control, and regular exercise are ways to help that process. So, there's two different main populations, and their familiarity with this condition will be vastly different, at least this is from my experience. The people who are type 2 will come in and they're seeking help. The type 1 people, they want to work out and they want to be fit, but they know their situation, and they know this very well. We talked about gestational diabetes mellitus, where it's a condition during pregnancy in which glucose levels are elevated, and other symptoms appear during pregnancy in women who have not been previously diagnosed with diabetes, etc. And I'm not going to belabor the point here, but they know that 6% of all pregnant women in the United States are diagnosed with gestational diabetes. It typically includes dietary modifications and exercise for treatment, but when those don't work, doctors may prescribe medications or insulin. All right, the book does define and describe the condition hypoglycemia, where a person has low blood glucose levels. Generally speaking, if your client has diabetes, what will end up happening is they will be skilled at administering the appropriate number of units of insulin, or have a strong understanding of their nutritional requirements. So you don't have to worry too much about it. But you do need to be aware of some of these symptoms, right? Sweating, hunger, palpitations, headache, tachycardia, anxiety. They might not feel good, etc. And they just might miss out. They might have missed a meal, or they missed in terms of nutrition. And you have to be able to recognize that. I'll let you guys pause this and read through this. But if you look at the mode of exercise for clients with diabetes, it could be aerobic, it could be resistance or flexibility. This is what they recommend as per the American College of Sports Medicine. Please pause, read through it. To a certain degree, you can work with your clients feeling pretty comfortable within these guidelines, but I will tell you, if your type 2 person comes in and they become better fit, you'll be able to progress from some of these guidelines, that's for sure. And your type 1 person, they will sometimes already be fitness oriented, and this won't be enough for them. So it just is dependent upon and having an understanding of your client and knowing what they can or cannot do and what their exercise history actually is. So with this, I'm going to break off and move on to the next presentation, my friends.